Yes, then we go on in the program. We come before the lunch break to the last talk, and that will be uterine leiomyomas. I ask Kristian Ivanov to come. Yes, here he is already running to the podium.
Hello to everyone. I saw the name of the session and it says embolization saves lives, and I would like to say that with this method, uterine artery embolization, it creates lives. So together with Docent Elizaveta Volcheva started to make this procedure 2014, 2015, we have several hundred cases and more above 10 children born after this uterine embolization. So, what are the fibroids? Fibroids are common benign tumors. They are common benign tumors that grow in or on the wall, the muscular wall of the uterus, often referred to as leiomyomas, most commonly called fibrom. They range from tiny to very large and sometimes can cause severe symptoms. They are very frequent in about 30% of the women, in who 25% have severe symptoms and need some kind of treatment. This procedure is known to the medical specialists from more than 30 years. It was late 80s, in the early 90s, when in the United States started to do this procedure. This is a non-surgical option. Techniques continues to improve, and what I mean here with the wall treats all the fibroids. The only other procedure which treats all the fibroids at once is total hysterectomy. So it has the same results at once, not all kinds, but all the fibroids which are in the uterus at the same time. In the late years, we started to treat adenomyosis as a lonely disease. 10 years ago, we tried adenomyosis only when concurrent to myomatous uterus. They are very common, they are benign. They originate from the smooth muscles, and they have 4 main locations. I cannot show. Okay, there are 4 main locations. One is submucosal, the other one is intracavital, often pedunculated. They are where the baby sits, and they are subserosal. They can be from the abdominal side and from the outer side of the uterus. Especially these which are at the abdominal side, and if they are pedunculated, we do not touch such fibroids because the heaviest complications occur with such kind of fibroids because they tear up and go in the abdomen and make sepsis. So there is another classification which says that if they are only 1/3 promenading outside the outer contour of the uterus, we can treat them safely. And intramucosal, they are all inside the muscular wall. The main indications for this procedure is heavy and prolonged menstrual bleeding. It's the main one of the indications. And the other one, which, according to my opinion, the women's seek medical help most of the bulk symptoms. These bulk symptoms are pelvic pain and pressure, urinary frequency, hesitancy, and retention. And of course, painful sexual intercourse, constipation, back, flank or leg pain. Sometimes such women are treated for ischiasis, and they have fibroids at the same time. And in the last years, we treat postpartum hemorrhage. Postpartum hemorrhage sometimes happens when a baby comes to the world, and if taken quick measures, it can save the organ. Because it's known that if heavy bleeding after giving birth, every 4 or 5 minutes, one death, if not treated, of course. And another indication in the last years, it's bleeding in gynecological malignancies. This is, how to say, it's preoperative. Treatment of fibroids and adenomyosis. Success is 95% satisfaction of the women with bleeding at 1 year. 80% satisfied with bulk symptoms at the first year. This is the third checkpoint after the procedure. 86% satisfied at the third year. And the course of the shrinkage is about 40 to 70% shrinkage of uterus and fibroids at the 6th month. And after that, there is an acceleration, and at the end of the first year, it's about 80 to 90% shrinkage from the initial dimensions of the fibroids. Large fibroids, which are more than 10 centimeters, treated safely also. We have one such case with 17 centimeters. It caused heavy constipation, sibilance. The woman signed an informed consent, and she did not want to be operated. But it was successful. It was a happy end with this woman. Pre-embolization evaluation. Gynecology and radiology consult are obligatory. The gynecologists have to exclude pregnancy, malignancy, current or recent infections, especially in the pelvis and in the urinary tract. And the radiologists have to make such slices to see the dimensions and the locations of the fibroids. Fibroids are almost never only one. They are more than one. And they have a tendency to cluster together. So when someone tell me that the woman have only one fibroid, a red line blinks in my head, and I try to recheck for malignancy, because sarcoma and leiomyoma can be differentiated very hard, even on MRI. There is a questionnaire for quality of life. We have to exclude allergies, chronic kidney disease, and they sign an informed consent. There are several imaging which are done before the procedure. The first one, it's a preliminary one. Most of the women come with sonography. It's a good image for seeing the fibroids. The next step is to make a CT scan with contrast and MRI with gadolinium to see exactly where are the fibroids, and to see the anatomy of the vessels. It's very important to see the anatomy of vessels, and if there is contralateral or blood flow from somewhere else, especially from the ovarian arteries. The technical aspects, this is a picture. You see, I will tell you after that. You see that the vessels which feed the fibroid are much bigger than the vessels which feed the healthy uterus. It's very important to choose the right dimension of the particles. You have to choose bigger particles, 700, 900, even 1000, because usually the bigger particles go only in the big vessels which feed the myoma, and they can't go in the healthy uterus. So we protect the healthy uterus with such big particles. We make local anesthesia. We use radial, only radial, and or brachial artery if the wound is too long. We use 5 French diagnostic catheter, if needed, which comes very rarely. We use guiding with microcatheter if the arteries are very tortuous, and especially after myomectomies, and after that it's a complete mess in the pelvis after operation of such a woman. Different kind of particles. The key concepts are spherical. It is better to be calibrated, the particles, for to know exactly what is the diameter of the particles, because most of the particles are 200, 400, 400, 600. You don't know what exactly particles you put in the arteries. During the procedure, we give mild sedatives, especially anxiolytics, antibiotics, which you usually start the day before. Monitoring blood pressure and heart rhythm, it's during the procedure, and we check constantly for signs of pain. If there are, then we immediately start the painkillers and infuse salines. This is in the during the procedure. Here I've shown different stages of this procedure. At the top left corner, it's the starting point. Then you see this tree of big vessels, how it crops. And at the end, we have only left part of the main uterine artery, and we try to spare the vaginal artery. And if the woman wants to get pregnant, we make super selective embolization to spare maximal healthy tissue of the uterus. Then we use a microcatheter, and we try to be super selective. Post-procedural observation and treatment. We use continuous intravenous infusion of narcotic analgesics, dexamethasone, 3 doses every 12 hours, Zofran, 4 milligrams every 8 hours. Here, this combination, narcotic analgesics and Zofran, I was consulted by an anesthesiologist who told me that there is a serious additive effect between Zofran and narcotic analgesics, and I persuade myself that it's a very good painkiller, the combination. Antibiotics continued after discharge for several days, Peros. Intravenous paracetamol is a very good painkiller in this kind of procedure. We give intravenously 1 flacon every 4 hours. It's during about 6 to 8, maximum 10 hours, the pain course. After that, they have no pain. The pain usually stops 6 to 8 hours after the procedure. Post-embolization follow-up. Post-embolization follow-up, we make imaging in our institution routinely performed at 3rd, 6th, and 12th months after uterine artery embolization to quantify the volume reduction in the uterus and leiomyomas, volume reduction of dominant fibroids, who is the greater, and that of the uterus. And after that, sometimes we follow up with ultrasound. It's beyond the 1 year period. And here I can say that we had a woman, and I looked in internet, there is no such case described in the literature. We have one woman, 2 embolizations, 2 childs. It was a young lady, 29 years old, just married. She was desperate because family problems. And he had a myoma 108 millimeters. It's about 11 centimeters. We embolized this woman and told her to get pregnant 1 year after the embolization. But at the 8th month, she came to us already pregnant. But she gave birth of a beautiful child. After that, because of the hormonal induction during the pregnancy, we made a second embolization 4 months after the childbirth. The big myoma shrank to 2 or 3 centimeters, and he gets another pregnancy with successful childbirth. I think, not sure, but I think this is the young lady which I described just before. The 7th month, it was 4 centimeters, and 1 month later she was already pregnant. And after that, these are much later consultations with sonography, and there are also MRIs, which are not here. 3 years after the 2 childbirths, these are the small 2 or 3 millimeters several myomas, which stayed steady 7 or 8 years already. Complications of uterine artery embolization. Acute complications from the access site, they are very rare nowadays when using radial approach or brachial approach. Contrast agent allergy, we can manage, in fact in the lab it's manageable. Thromboembolic events, many women are pretreated with hormones, and there are described several cases of thromboembolic events after this manipulation. We haven't any of such kind, but they are described. And especially because of mostly the best women have large fibroids, and they have venous problems in the legs, and they stay motionless about 12 hours, so it can happen. Pulmonary embolism if AVM exists. So I always check for arteriovenous fistulas before starting particular administration. You should make one prolonged good injection with a venous phase, because there are described 2 cases of pulmonary embolism after this procedure. But I think it's operator's mistake. They were administered 16 vials of particles with no effect over the fibroid, and they go through fistulas to pulmonary circulation and make pulmonary embolism. Pain control, especially in women with low pain threshold. Uterine infection. Endometritis, endometritis and sepsis are rare complications. Sometimes they occur weeks to months after the procedure. So this is the pedunculated fibroids which are on the abdominal side. They make such complications which are major complications. Uterine ischemia. The goal of this procedure is to cause ischemia and necrosis only to the fibroids while preserving the uterus, but sometimes it may happen. Uterine necrosis is a rare major complications demanding urgent hysterectomy. We haven't such major complication. Because the first recommendations were to use 400 to 5 to 600 particles, but it's not useful. You have to use much bigger, 900, 1,000, rarely 700. When you use smaller particles, they go in the healthy uterus and they can damage the healthy tissue. Spontaneous expulsion of fibroid tissue, it sometimes happens. We tell the women that this can happen. They take the fibroid which they have in a jar and they go to the gynecologist to make a histology. Chronic vaginal discharge sometimes happens. And it resolves spontaneously over the next few months after the procedure. Ovarian and sexual dysfunction, mostly transient. Only a small group of about 6% developed amenorrhea, and it was observed exclusively in women above 45 years old. Treatment failure, very small percentage, when incomplete embolization, arterial spasm, recanalization of the arteries. Sometimes the permanent embolization recanalizes for unknown reasons. Prominent non-uterine artery collateral supply, often from the ovarian arteries. You can embolize an ovarian artery, but it's better not to do. If you can go, the ovarian artery originates just below the renal artery and it's very thin and tortuous. So sometimes it's possible to get a microcatheter to the ovarium, and there are two main branches, one the ovarian and the other the fibroid, and if you can reach the fibroid branch, you can embolize the fibroid. And if there is a communication, there is a special technique with hand training for the individual woman who is lying before you on the table, and you train your speed of pushing the particles, and when the collateral blood supply overcomes your push speed, this is the speed with which you should insert the particles, and the ovarian artery is spared, no problems. Post-embolization syndrome, it occurs almost in every woman, but we usually discharge these women the next day, 24 hours after the procedure, they are healthy. And the conclusion, uterine artery embolization is an increasingly popular minimally invasive treatment option for women with symptomatic fibroid disease, well-tolerated procedure with a low risk of complications. Thank you.
Thank you for this overview. My experience is more or less similar. Complications are very rare.
Very rare.
And it's much easier than other embolization treatments in that area because we have an uterine artery on both sides. And when we know how the blood supply of the adenoma is, then I can use one or the other one. So that is fairly safe. And because I see that Ivo Petrov is also here in first line, so perhaps next year, which is much more complicated, that is embolization treatment of the prostatic gland, because as you know, every man older than 60 has an enlargement there, benign adenoma, yes. Also carcinoma, you know, that's the most frequent tumor in human,
Yes.
in man. Every ninth man, look at 9, will get a carcinoma. But adenoma is also treated very successfully with embolization, but that's more complicated because you have not an artery for the prostatic gland, but there are many small branches, and you need quite a lot of experience when you do that treatment. With the uterus, it's much simpler, but I will not give another talk here, but only ask if there is some experience with other colleagues here.
We treat prostates also. It's the same technique like in the uterine artery.
Yes, but it's more complicated because you have many several arteries, and I know that there is more complications also when it's not well done, even with penis necrosis and so on. Yeah, so that. No questions?
What are the effects when there is a subendothelial myome and you embolize it? So does a woman that is in maternal age have problem with getting pregnant? Are there any studies on that? In how many percent of women occur some kind of fertility problem afterwards, or placenta previa or something in those regards?
The percentage is very small. So in I wrote the statistics, it was 10 to 12% is said to have some fertility problems. But as I wrote, it is older women, above 40, above 45, they have such problems, yes. And it's often happen miscarriage in such women, not big percent, but it's described 10 to 12, and after 45 years old, to 40% miscarriage after this procedure.
I just want to make a comment. Congratulations about the results and everything. Because, of course, the gynecological surgeons, they like to do the operation and the so-called myomectomy. But there is a very, very strict statistics showing that all over the world, 7% of the plant myomectomies are finishing, in fact, with hysterectomy. And definitely, the embolization, it's much, much safer in regard of this dreadful complication. And also we have a very good experience. We don't have too much, but probably we have 4 or 5 women per year with embolization of leiomyomas. And several of them were, in fact, referred by gynecologists after many years trying to get pregnant. And in fact, this is the second advantage compared to surgery. So after embolization, the probability of getting pregnant for a woman in a childbirth age is bigger than after surgery.
Both groups, so after embolization, they have a better chance of getting birth during labor and deliver the baby compared to the myomectomy group. For at least it was 16 to 18% better percentage. They include only women in childbirth age.
I've only women who want to get pregnant and they come to us for embolization. All of them They gave birth. Only one have miscarriage. It was 42 years old, and the second attempt was successful.
So you
42
confirm
years old.
the statistic from Netherlands and Belgium also.
Thank you very much. Yeah, in fact, thank you very much for the session. Thank you, Professor Matthias. Two announcements. We are going for lunch now. And I would like to ask you to be here back at 1:45. So several minutes before the session in order to have some small ceremony of opening the Congress. This is first. And the second, at the end of the corridor, there are several simulators, so hands-on sessions. Everybody of us, during the free time, please visit end of the corridor on the right, on the Abbott vascular room. You are going to have the possibility to have hands-on on the simulators. Thank you very much once again.
On my